Hello and welcome to your Hospice and Home Care Webinar Network program. My name is Sydney and I'm your host for today. You can message me directly in the Q&A box for any technical assistance during the webinar and I will help you out. Today's topic is Hospice 101 Orientation and Refresher Basics, Documentation, Eligibility, ITG, and LCDs. If you haven't accessed today's webinar materials, I encourage you to do so. The materials can be downloaded and viewed from your webinar instructions email. Today's presentation is about 90 minutes, including 2 opportunities to ask questions. However, you can type your questions and comments into that Q&A box on the right side of the screen at any point during the webinar. And if you have additional questions afterwards, I have provided the presenter's email address on the first and the last slide. Today's program is sponsored by your Hospice and Home Care State Association. It is directed by the Hospice and Home Care Webinar Network and produced and presented by Kathy Ahern of Ahern Advisement. Today's speaker has 30 years experience serving the healthcare community, a bachelor's in both nursing and social work, and owns Ahern Advisement Partners. She has worked in a variety of post-acute care settings with an emphasis on home health and hospice, home infusion, home care, and skilled nursing as a PICC compliance expert. Kathy began healthcare work due to a disabled parent and later a child living with chronic disease state. She has experienced healthcare professionally and personally, dedicating her life to it and working as a change agent for the betterment of all. As you can see from her full bio, we are in excellent hands today. So without further ado, I would like to turn the program over to Kathy.
Great. Thank you very much, Sydney. I appreciate the introduction, and it's very nice to be with all of you today as we jump right into Hospice 101. So our goals and objectives for today is basically we're going to help you identify who is eligible for the hospice Medicare benefit. We're going to define what documentation is required to support that Medicare-eligible hospice admission. We will explain the 4 levels of care and what documentation is required, so you will be able to do that as well. Explain for the CMS conditions of participation what is considered hospice core services. We will be able to identify what is required under the new hospice benefit election statement and addendum. So that went into effect October of 2020, and so we're going to discuss that today so you have an understanding of it. We will also help you understand what the benefit of using LCDs when documenting are for greater accuracy. And of course, just a simple definition, we're going to define the difference between hospice and palliative care, because I know many times when we have new staff, it is a little bit important to make sure that we help them with that differentiation. So let's just start in the beginning. And hospice was established in 1983. I should say the Medicare hospice benefit was established then. And it was considered a model for quality care for people with life-limiting illnesses. Provided Medicare beneficiaries with access to high-quality end-of-life care, which prior to that we weren't really dealing with end-of-life care issues in this type of a forum. It's patient-centered, cost-effective philosophy of care. Hospice uses an interdisciplinary team of professionals, so it is team-driven. It provides compassionate and expert medical care, pain management, emotional and spiritual support that is tailored to the patient's needs and wishes, which we will learn is a hospice value. And the growth and increase in the Medicare hospice benefit utilization has been related in recent years to more of the non-cancer terminal diagnosis, such as heart disease, COPD, Alzheimer's. So when the Medicare benefit of hospice Medicare benefit first started, we really at that point in time were looking more at the cancer diagnoses. So just to let you know that we have advanced a lot from that point in time, but I will show you later in this presentation a breakdown on generally who is served and what type of a diagnosis. So the Medicare hospice benefits, these are the requirements, very simple. Patient must be eligible. They must sign the election of the Medicare hospice benefit. There must be a physician that certifies and recertifies that the patient has a life-limiting illness. And the way that we usually discuss that life-limiting illness is we talk about if the disease were to follow its normal course, that we have a prognosis of 6 months or less. There's an establishment of a benefit period. It does require a face-to-face visit for the third benefit period or greater, so anything from the third benefit period on. Of course, a plan of care must be established, and there must be an interdisciplinary team or group. So hospice is not about a one-man show. Hospice is very much about a interdisciplinary team, and we will identify the players in the team also. So what are the hospice values that are critical to the hospice philosophy? So let's just talk about a few examples of those. Number one is service. What we're looking for in hospice is helping to identify patient needs and responding and identifying to any service failures. So oftentimes when there are audits being done, or if there are, you're turning in quality assurance reports, many times those challenges can look and be linked to service failures. So service is very much at the forefront of hospice. Of course, compassion. How many of you, the minute you say to somebody that you are involved with hospice, you work for hospice, whatever, everybody's demeanor changes then when they address you. People that work in hospice are oftentimes described as angels. So compassion is of course, the capacity to care, to have empathy and active listening, which is very much a hospice value. Dignity. Dignity as it relates to the patient's and family's culture, their spiritual beliefs, and their practices. Excellence, which again, we're going back to quality on that, quality of care. Patient and family choice. It's very important that we understand the importance of the patient and family choice in the decision making. It isn't about what we should say they should do. It's about making sure that the patient and the family has an opportunity to make choices in their plan of care and what's going to be taking place. Of course, we talked about teamwork, and teamwork always provides an opportunity for creative problem solving. And we'll see as we're working on plans of care, eligibility, where the teamwork really comes in, and of course integrity, which is terribly important because integrity leads to, of course, confidentiality with the issues that we're dealing with, and confidentiality sometimes can actually even take place when you enter a home from one room to the next. So it's important to understand confidentiality comes about in many different ways, and accountability when we're looking at integrity. When we're discussing hospice versus palliative care, it's important to know that both offer compassionate care, but palliative care is more, it's a component of hospice, but in palliative care, it's actually about you're focused on relieving symptoms, but the patient's also still able to get active treatment. Generally in hospice, patients are no longer seeking active treatment. Now, I do not want to confuse anybody by this next statement, but there are different payment models that are coming into play and are being rolled out by Medicare, where they're actually beginning to look at, and now these are just pilot payment models, but they're actually looking at, will it be beneficial to actually allow patients to have some treatment while under hospice? Would that allow more patients to sign on to hospice? So you probably will see some of that coming down the road more as time goes on. But currently right now, active treatment is palliative care where hospice is not. Okay, so it's important to know that as last October, October 1, 2020, Medicare came out with modifications of the hospice election statement as it related to the content requirements. What they stated, they didn't say this is what the form needs to look like. They left that to the discretion of the agencies, but they stated that there must be specific language that needed to be added to the election statement. And a lot of this language deals with, and it's about transparency, what is covered, what is not covered, so, and what is related to the diagnosis and what is not related to the diagnosis, so there isn't any confusion. So that is why we're talking about transparency and adding that to the hospice benefit election statement. And then they added another piece. They wanted a addendum. And the addendum, the purpose of the addendum was actually to notify the individual, or if there was a representative, you know, a family member, anyone who's power of attorney or whatever working with the patient, it was important to notify them in writing of those conditions, items, services, drugs that the hospice will not be covering, because the hospice has determined that it's not related to the individual's terminal illness and related conditions. So again, before there could be some confusion related to if a drug was covered, if a piece of equipment was covered, if a particular service was covered. But now with the addition of the addendum, that clearly needs to be defined if something is not covered by the hospice, and that is in the addendum. So the addendum must include language that the immediate advocacy is available for the patient and or representative should they not agree or have questions about what is covered or what is not covered. And that goes back to the Family-Centered Care Quality Improvement Organization. Of course, we're in healthcare and we have a million acronyms. I provided you with the acronyms here in the presentation. The name and signature of the individual or representative, the date, and must, of course, be placed on the addendum. It's terribly important that we go through that. And also, it's also important to know that you must offer the patient and or the representative, if they should want a copy of this addendum and the new election statement, you have to provide that to them. And hospice has particular, CMS has particular time frames on that. I didn't identify all of those time frames in this presentation because there are about 3 or 4 different ones, but initially you're looking at if the patient should want a copy of what they signed and what's covered or not covered. You've got about 5 days to get that out to them. But during the course of care, if there should be changes to the plan of care and certain, say, medications are no longer covered or certain treatments or services are no longer covered, that addendum needs to be updated and presented to the patient, and again, another signature goes out. So this is a continual working document that's an active working document, again, for the sake of transparency. And it's also important that this information goes back to the physician and other individuals involved as to what your hospice will be covering and what it will not be covering. And again, families always have a way to advocate if they are not in agreement with what you said we can cover or not, and that is indicated on the form. Now, for people new to hospice, Medicare is always very generous about providing templates that you can follow. So if your hospice has not implemented this yet, this is critically important because it was effective October 1, but trust me, I've heard hospices not implemented this yet. Go ahead and grab the template off of the Medicare website and just use that to get going with and familiarize your organization with it. You don't need to recreate the wheel or start from scratch is what I'm trying to say. Medicare does leave that to your agency to design that form the way you want, but again, they provide you with a template. So now let's talk about the core aspects of hospice care. The core aspects are, it's a patient-family-focused care. Again, we talked about an interdisciplinary care team of professionals, and they provide a wide range of services, what we call core services. So interdisciplinary case management, you've got pharmaceuticals that are, of course, related to the prognosis, supplies related to the prognosis. Of course, there are volunteers, which are part of the core services, and grief support. So it's very important to understand what are the core aspects of hospice care, core services that are provided. Now, these are other things, other additional services that can be offered by hospice. There can be, some hospices have a hospice house. Oftentimes you'll see some type of a residential care that they're affiliated with, or they may have designated beds within some type of an inpatient facility that are their hospice beds. So that's an additional type of service, and actually that's been a little bit more on the rise, creating a residential care or inpatient hospice care unit. Some hospices offer palliative care. Some have complementary therapies. We're talking music therapy. We're talking, massage therapy, a variety of things. Some hospices are specialized in pediatrics. Not all hospices do pediatrics, so it is important to understand when you are working with a patient or you are referring somebody, because the minute I say I work in hospice, I get a question almost every time. And, I was answering a series of questions yesterday as I was doing some work in a clinic, not about the patient's diagnosis. They were asking about hospice for somebody else. Hospice also can provide caregiver training and community bereavement services. And I want to hover about that community bereavement services for a bit, because it's becoming more, I don't want to use the word popular, but more available in the communities, especially now as we've had some as we have this COVID situation going on. People do not necessarily have to die in a hospice service in order to benefit from some of the community bereavement services. Actually, I just plugged a patient yesterday into a hospice, their grief support, who lost her husband suddenly, and the hospice with open arms greeted her into supporting her with some bereavement services. So oftentimes that is actually a good community service that a hospice can provide. Okay, so now let's talk about that very important team. So you will hear the interdisciplinary team can go either IDT, IDG, these types of abbreviations. So who is on that team? Generally, the medical director of your hospice is on that team. The attending physician, which is the patient's attending physician. An RN and an LVN, LPN are part of that team as well. Your hospice aide, social worker, volunteers, the pharmacist who is providing the medications, and when you do IDT, IDG, oftentimes you do have pharmacy representation, whether it's virtual or something like that, or they give an update, but it is good to have pharmacy support during your conferencing, chaplain, therapists, and caregivers. So as you can see, this is a team that brings a wide variety of information in to deal with total patient-centered care. And it's very important that this team works together in developing a patient's plan of care and continuing on with the Medicare eligibility. So what is the role of that hospice team? What's their purpose? What do they do? Team members help to develop the plan of care. So like I said, this isn't a one-person show. This isn't a nurse going in saying, this is the plan of care, this is what I think it should be, end of sentence, doctor, sign it, off we go. No, this is about the nurse developing the plan of care and bringing it into the team for the team's input as well. So we're looking at symptom and pain management. Of course, the team is attending to the emotional, psychosocial, and spiritual aspects of dying and caregiving. The team is also teaching the family how to provide care and supporting that family in providing care. The team advocates for the patient and the family. The team provides bereavement care and counseling, and the team is also part of the Continuum of Care. And these days, that Continuum of Care is very, very important, whether we receive a hospice referral from a facility or a hospital or from the community. Just keeping that Continuum of Care is very critical. Also, where can hospice be provided? And I always say anywhere a patient calls home. Now, the majority of patients receive hospice, what's known as routine home care, in their home. But there are some patients that are in nursing facilities, in assisted living facilities. Sometimes you will see patients in the hospital starting with hospice there. You can see, as I mentioned, a hospice residence or unit, a hospice inpatient facility or hospice house, a correctional setting, homeless shelter, a hotel room, motel room, anything like that. Wherever the patient calls home is where hospice can be provided. So I mentioned earlier that, cancer was really the leading diagnosis for why hospice started and the end-of-life care discussions. But what has taken place now is we certainly have other diagnoses that are factoring into how we distribute the U.S. hospice deaths. So looking at 2018, which was the most current available report that I had, and NHPCO every year puts out the statistics, and this is from them. Cancer, as you still see, is almost at 30%. So I look at this every year, and I'll tell you, it might have been 29.8% last year, and it's 29.6% this year. These percentage points have not moved a tremendous amount, like 0.2, tenths of a percent. So we've been looking at similar numbers now for the last couple of years. Generally next year looking at cardiac and circulatory issues for hospice diagnoses and deaths, dementia, respiratory, stroke, other, and chronic kidney disease. So this will probably be the breakdown that you will see in your own hospice if you, keep your data and look at your breakdown on how, what your deaths look like and what your admissions look like and what type of diagnosis. If we look at the 2018 stats as far as length of stays, median length of stays, do more females join hospice than males? You can see, yes, it was almost a 9%, well, it was a 9% difference for females to enter hospice in 2018. The average length of stay was 75 days. The median length of stay was 18 days, and that's a pretty quick turnaround, 18 days, to really truly be effective in a patient's life. What's even sadder is when you go down to the 1 to 7 days as the length of stay or total days of care. Look at that. That's almost at 28%. Basically, all that the hospice is able to do in that first week is an assessment, get the meds out, try to get the team in as quickly as possible, get the equipment out. But from a supportive standpoint, it's really a challenge when you have a patient that's on care only 1 to 7 days. So this is really where bereavement services kick in quite a bit as well. I always feel a tremendous amount for the patients who have only benefited from a 7-day hospice on service, because that really does not give family or everyone a good preparation for this. And many times it's just about the doctor not wanting to say, sign that prescription, sign that certification about, if the disease follows its normal course. You can see as we move down the spectrum here, 8 to 14 days, 15 to 30 days, there used to be a rule of thumb that the best number of days that you could have a patient on service where you actually really could start making a difference and getting your arms around the situation and supporting the family and getting the team in and doing everything to the best of your ability was about 42 days on hospice. That's when providers, agencies felt like they could give their best. That's when families were also feeling pretty good. So, it is important to try to get patients on hospice sooner than later if they are eligible, and of course we will be discussing that. And that's purely just because we want patients and families to have the full benefit. So there are 4 different levels of care in hospice. I mentioned routine home care, where the majority of the care is delivered. There is general inpatient, there's continuous care, and there's respite care. What is most important when you are dealing with the different levels of care is that you begin documenting the date that there was a change in the patient's status and condition and their care requirements. And we're going to go down, we're going to discuss that a little bit more here in a few minutes. But again, it's important to start documenting the moment you see that, the moment you're going to move into a different level of care, because of course there's a different reimbursement rate affiliated with it also, but then you have to have supportive documentation, of course. So when you have an increased level of care, some of your eligibility requirements. So let's talk about general inpatient or continuous care. And this is usually for something that the IDT, IDG has come together. You've got a patient where you cannot get those symptoms managed at home. You've done everything that you can. It's documented in your notes. This might even be a pain management issue. Patient may have to get admitted, might have to go onto an IV drip if you have an acute exacerbation of pain, just to get that under control, to convert it, to put them on a PCA to get them home, or possibly, if you have an acute case, or possibly, to convert to the patches and everything. But a lot of times you're really looking at chronic symptom management. And again, this has to be something that you have not been able to manage at home, and it better be documented that you showed all of the different things that you tried to do to manage it at home, and it couldn't be controlled at the routine home care level. You must have a need for professional nursing management to control symptoms. So it can't be just custodial care. I mean, you've got a patient that comes into a facility under general inpatient, and your nurse is going out every 8 hours to manage that symptom. And there's documentation going on there because we're trying to see, we did this, how did our intervention go? Did we do symptom management? Do we need to change something or do something differently again? I mean, it's that intense of nursing management. Also, we need to identify what has been tried to resolve the medical crisis, like I said, at home, that's not worked, in order for the patient to be there. Not only are you managing the symptom and trying to get it under control, but I always say the minute someone's admitted somewhere, you need to begin on the discharge plan. And so immediately, as you can see, you need to include a plan for return to the home, to return to routine home care from the beginning of the elevated level of care. So after you manage the symptoms, and get everything under control, what's the plan to send this patient home to routine home care level of care, and how are you going to continue to manage these symptoms? So there must be an identified plan. So we're going to now go into the COPs. I just broke them down into a couple of pages for you. This is something that you are able to, I've provided you with a link both here and at the end of the presentation. The COPs are online, they're electronic. If you want to print them, and also the interpretive guidelines, goodness gracious, it's 100+ pages. So I highly recommend that you look at everything online if possible. But this shows you where in Chapter 42 CMS talks about hospice. And so as you can see, they have their different subparts. We talk about general provisions, eligibility, election, and duration of benefits. Then you've got the patient care, where you're looking at both the initial and comprehensive assessment of the patient. I mean, CMS outlines exactly how this should go. We're looking at, you've got the tag there, where is it IDT, IDG, the care planning and the coordination of services. It discusses core and non-core services. So it's very important to familiarize yourself with the COPs and the interpretive guidelines. We also look at, in the interpretive guidelines, the organizational environment. So, emergency preparedness, as we know, has become a very big topic in the last few years, especially now we've got a global pandemic. So that is part of the organizational environment. We're looking at personnel and their qualifications, clinical records, etc. There's also a breakdown, and we're not going to go into this piece today. We tend to discuss the hospice cap a little bit more in our Hospice 201, but how services are paid for, and then what's the reporting and record keeping that hospices must do. So I just wanted to make sure that I pointed to where this area was for you in Title 42 of Chapter 4, and so that you can go ahead and begin to familiarize yourself with this area as well. And don't let the interpretive guidelines overwhelm you. Part of our presentation today is to kind of horn in and focus you in on how to get documenting, how to determine eligibility, et cetera, so that you can avoid some of the pitfalls and challenges that come up. But anyway, again, don't let it overwhelm you. Just try to break it down and take advantage to learn it in every opportunity. So how do we pay for hospice? Hospice is paid for in a variety of ways. The majority of hospice is paid for with Medicare. There are Medicare interpretive guidelines and there are Medicaid interpretive guidelines for hospice. Insurance and HMOs, generally you're looking at Part D that will cover it. There are private pay. Sometimes there's a combination of things that help pay for this. I wanted to break down kind of let you see what the reimbursement was to give you an idea of what we're looking at. So under routine home care, which is your 651, you can see that for the first 60 days you have a higher amount that you reimburse daily, and then after 61 days that does go down a little bit. But it is considered that the majority of your work, there's continual support, continual monitoring, continual everything with hospice, of course, that when you're setting a patient up, as I'd mentioned that 42 days before, there's a lot of work on the front end. And then depending on the course of how things happen with the patient, if you've got everything monitored and things are going well, then you might have a few moments, a couple of times there might be respite, something like that for the family. But another opportunity then is at the end as patient is declining possibly rapidly, then you will generally see an increase of services and the need for more staff as well. So it really is about managing where the patient is on that continuum with their illness and their disease progression. You can see that continuous care goes up to $1,400 approximately. Inpatient respite care we've got there, and general inpatient care here also. So that was just some numbers to help you take a look at to get an idea. But I think we'll take our first quick break there if there are any questions, Sydney.
Thank you, Kathy. At this time, if you have any questions or comments, please put them into that Q&A box on the right side of the screen. We did have some come in through private message. Does hospice need to offer all services?
No, it does not. It needs to offer the core services that I talked about, but no, it does not need to offer all services. And I'm going to be really honest with you. When I first got into all of this a long time ago, I found many hospices that were first getting started actually not offering some of the services, which really shocked me. Later, that almost became kind of a marketing tool with different hospices by adding more additional services. So what's critical to know is what are the core services, what do the COPs say, and what do we need to provide. But if you really want a robust hospice program, and especially if you've got palliative care alongside, you may even have a home health with your agency where you're going home health to palliative care to hospice, to be able to offer more services is actually very attractive to not only payer sources but also to patients, caregivers, also case managers, referral sources, etc., because patients have multiple needs these days. So I find that hospices with limited services, it does impact the quality of care. I don't want to speak poorly about anybody, but it does impact the quality of care and what the patient does receive. Oh, I see another question here. I'll just jump right in, Sid. Do I see COVID-19 becoming an admitting diagnosis for hospice? So I am going to talk about COVID-19 in this presentation a little bit, but what I would like you to pay attention to as we start going through some of the diagnoses and how you have to pair them up, or, what's appropriate, or, comorbidities, etc. There's a lot of stuff with COVID-19 that might relate to cardiac, that might relate to respiratory, that might relate to, we're finding we don't have everything yet, but we certainly do have a lot more data we're getting, but these patients may actually end up in a palliative care type program that then transitions them to hospice. So I do see that this is going to be an opportunity for hospice to support the communities and look at ways that possibly bringing patients on with using a variety of diagnoses to get to an eligible admission. I see one other person typing. I don't know. Here we go. If we discharge a patient for extended prognosis and then bring them back in on a new certification period, do we still get? Yes. Yeah, so basically, if I'm reading this correctly, if they've been discharged off your service and you've discharged them, and then I'm assuming they're going to be off for a little period of time, I wouldn't think that you would want to discharge them and then admit them the next day. Then yes, you are able to get the higher rate. I will say this to you. I want to say this carefully. There are hospices out there that, as they're approaching, with the active life discharges, and they've got that extended prognosis or super long length of stays, we find that they will discharge, we as in some of us that audit, we find some hospices discharge for a very short period of time and then readmit. And we even look for patterns in that. So I want to caution you with that. But yes, your pay scale will start over on that. Let's see. Is that another question? No, I don't think so. I think that's the only questions left. Am I correct, Sydney?
Yep. So I'm going to turn it back over to the main webinar, but if anyone has any questions or comments during the second portion of the webinar, please put them into that Q&A box because we will break at the end as well for questions. All right, Kathy, turning it back to you now.
Okay, great. Thank you so much. So you're going to hear me talk a lot about LCDs, which is local coverage determinations. And I believe LCDs are critical, and they are not nearly used enough in hospice to help new staff, regular staff, old staff, help with documentation. So LCDs are guidelines that were established by CMS and the MACs to facilitate medical reviews of hospice admissions and ongoing service. So they came up with this information so that they could do medical reviews. So they were originally, LCDs were originally based on NHO guidelines, and the intent was to help increase access to hospice care, giving people guidance on, okay, this makes a person eligible, this does not, you combine these things, you can have that. So it was really to help guide people. So it really is a useful tool for hospices to utilize as a screening tool in the eligibility decision-making process. Why not think like Medicare and the MAC thinks? So whoever is your fiscal intermediary, it's important that you try to get their LCDs. Here I gave you a copy of a link to go get Palmetto's. Palmetto covers Texas and many other states. They're quite large, and they actually put their LCDs out on the web. So depending on who your fiscal intermediary is, I always recommend when I'm working with hospices, make sure that your staff has this so that they actually know how their notes are being looked at, how their notes are being screened, so they actually can have the tool that helps them as they're documenting. So why is it important to be familiar with LCDs and appropriate documentation? Because you're trying to make sure that the patient is hospice eligible. So you want to think like, and I'm calling them they, but you want to think like the payer source, in this case, Medicare, thinks and says, if the patient meets this criteria, this criteria, this criteria, and LCDs are a guideline for that. So Medicare auditors are trained to use the LCD criteria to make payment decisions. And so MedPAC has made recommendations for an increase in hospice program oversight, as we know, and that oversight has been incorporated now into TPE, and we'll talk briefly about that. And we do talk about TPE and other presentations, webinars, but it's important to use that because you can help avoid some audits down the road. So use the tools that you're being audited off of. You want to pay attention. It's really important to pay attention to your length of stays, to pay attention to your live discharges, and any of your supportive documentation that may have gone with this. If you have a high incidence of live discharges, that generally means that you are admitting people that are not appropriately Medicare hospice eligible. You might be admitting them a little bit too quickly onto service. So I would say to you, that's usually a guide in your QA department. So if you're benchmarking and you're looking and you have these a high incidence of live discharges, make sure your staff is trained on using the LCDs and looking at who is eligible. That's your first clue to tell you you've got a problem. The LCDs provide the best chance of reimbursement at the first level of medical review. And it's always good to focus on passing the first level of review, because you pass the first level of review, you get your money. Otherwise, you have to go back and forth with the process, and then you're hoping that, everything went well, but you're tying up people in the financial end, you're tying up clinical people. Depending on what's going on, you might be bringing in a third party who's auditing, who's not only just auditing, but they're actually helping you put the supportive documentation together that you're sending to hospice. And then maybe you get denied again and it's an appeal process. So that's why it's really important to try to get everything done on the front side so that you don't have to take all that extra time on the back side. So when I mentioned TPE, this is Target, Probe, and Educate. This is about auditing. So they're targeting, they're probing, and they're educating. They're kind of looking under the sheets and saying, where do we have problems? And so 3 areas of focus under these requirements in hospice are the technical and the eligibility requirements. So in technical requirements, it's just a valid election of the Medicare hospice benefit. So it's making sure that it is signed by the appropriate party, whether it's the patient and or the representative, that it is dated appropriately, because that can be very much a challenge. So that is what we're talking about there. And then, of course, now you've got the addendum piece that goes with it as well, too. And then under technical, you also have valid attending and medical director certifications, which include physician narratives and face-to-face encounters when we need the face-to-face encounters after the third benefit period, beginning of the third benefit period. Under eligibility requirements, the main thing they're looking for, and an area that's always a challenge for, hospices in getting audited, is are they appropriate for admission? Are they eligible do they meet the criteria? And again, that's evidence of a 6-month or less prognosis. Now, we know that sometimes people live beyond that 6 months. Actually, sometimes when people get on hospice service, they thrive. I mean, they're getting all this attention, etc., and we see them actually thrive. And so there might be a period of time where they actually perk up and stuff, but then after that they might start declining again. So it's very important to kind of pay attention to that. I mean, do you have someone that's thriving just because they've got some attention, but where are we going with this? And, you know, you can recertify, again, at the end of 6 months, but it's important to pay attention to that and what's going on with the patient. So under technical requirements, the Medicare election benefit must be signed by the patient or representative, and if it is not the patient, there is a line there to document what is the reason why the representative is signing it. The election date documented before services can begin. And so the election date cannot be earlier than the first day of hospice care. You can date it at a later date, but you cannot date it before, because technically you start billing from the day that they elect services and you go out there. At the time of the admission, the patient must be certified as being terminally ill with a prognosis of 6 months or less if the illness runs its normal course. It must be certified, as I mentioned, by 2 physicians, by the attending physician. The attending physician is the patient's attending physician, might be the physician that actually referred the patient to hospice, and also by the hospice medical director. The attending physician generally is chosen by the patient, has the most significant role in the determination and delivery of the individual's care. And choice of the attending physician, it's important that we realize it's a patient right according to the COPs. So there are doctors that do not want to refer to hospice. They're just not comfortable with it. But there are patients that want hospice even though their doctor does not want to refer to hospice. So a hospice may step in and they can make a recommendation about possibly another attending physician that might be willing to take the patient on and certify for hospice, but you can't coerce the patient into a decision. You know, with Medicare, we've got patients' rights and responsibilities. Nobody can be coerced. You have to be presented, let's say, presented opportunities in order to have the benefit occur. But again, it's important not to coerce. So if the attending physician does not want to sign on service, many hospices actually have a couple of attendings that are willing to work with them that they use for these types of situations. The attending is also considered part of the hospice team, including the plan of care, and especially if you have levels of care where you're having changes, the attending is definitely involved in that. And another thing too, just so you know, if a hospice patient is in a nursing home, many times the attending physician will become that medical director of the nursing home as well. So just food for thought there. There needs to be certification of terminal illness by the physician on admission, and if there's recertification required, they must have a verbal or written certification within 2 calendar days of admission, may be obtained up to 15 days prior to election. Written certification must be present before submitting a claim. So, you know, if people are eager to submit that claim, but you don't have that certification yet, you cannot submit that claim. You need to make sure that you've got these certifications in place. If the signed certification is more than 2 days after admission without a verbal, the billing date starts the day the certification is signed, and earlier days are lost. So you can get a verbal certification and start hospice then, and then go into the home and have a signed certification. But timing is critically important here, as you can see on the certification of illness, terminal illness. Physician required to date his or her own signature, so there's no predating by staff, no post-dating, no stamp dating. We do electronics now, so there are things that are allowed that way. Regulation specifically requires the physician certification determination must be based on clinical information and other documentation. It must be documented in the medical record. and also included as part of the hospice's eligibility assessment. So that is all part of what's setting up the patient for eligibility. It is included in the medical record. So if you have an attending physician, yesterday as I was guiding someone through this, it's like your attending physician should have a note about the certification in their chart, in their office. It's important so there is that continuity of care as well. But also, regulation specifically requires the physician certification determination must be included as part of the hospice's eligibility assessment. Critical at the initial IDG meeting that verification occur of all required documents and supportive documentation of the physician and agency are in place. So what I'm trying to say there for you is, so you've got this paperwork coming in, you've got the certification, we're now doing the initial assessments and all of that, and you're looking at your IDP and your IDG, and you want to verify at that point in time that you do have all the required and supportive documents that you need. You may have to go back and get some additional, but that's where the team focus comes in because they can look at everything. A statement of certification that the patient has a prognosis, as I mentioned, expectancy of 6 months or less if the terminal illness runs its normal course. And that oftentimes can be difficult for some attending physicians to decide that they want to say that. That is why they refer to another attending, but anyway, that can be that one little sentence there, and also the fear of managing pain meds. Those seem to be the two things that spook doctors a little bit, but also it's important that there are dates of the certification, that needs to be present also. When I'm talking about a face-to-face, I just wanted to go over this a little bit too, because depending where we are in the certification process for eligibility, a face-to-face is required. So here's some considerations around the face-to-face. This is actually more of an administrative function. It's a clinical visit, and it's just really to make sure that the patient is still hospice eligible, and that it's required for 68 periods, third period and beyond. It cannot occur earlier than 30 days prior to the beginning of the third period. So patient gets admitted to hospice, you cannot do a face-to-face in the first month of admission and have that face-to-face work for your third benefit period. There are specific time frames that you need to look at here. Also, the face-to-face needs to be completed either by a hospice physician, a nurse practitioner, but PAs are not allowed at this time to do the face-to-face. You want to make sure that the documentation has pertinent diagnostic data, anything that might support the course of the disease, following its path, what we're expecting. We might be looking at albumin levels. We might see oxygen saturations that are getting worse. We might see kidney function with our BUN and creatinine getting worse. Our ejection fraction with the heart might be getting worse. So it's really important to pull together any of that information in a face-to-face to help support the eligibility. You want to review the status for diagnostic-specific LCD criteria. You don't want to skip any criteria. You always want to make sure that you document, you don't want to do overkill, but you want to build the story, you want to build the case. And I always say a great hospice is a hospice that when I'm auditing them and I'm reading a patient's chart here in my little tiny place in San Diego, I can cry when I'm reading about a patient because the hospice has done such a wonderful job telling the story. And I almost feel as if I'm in that patient's home because I'm both a nurse and a social worker, and I'm in that patient's home and I'm actually living those visits with you. and I'm going through the challenges that you're going through, and I just love a chart like that. So it's really important, and that's why I say, you know, we encounter some tough families out there, so it's always some of those situations that bring a tear to an eye, because I feel like I'm right there with you. I love when a chart tells a story. So you want to pull together anything and everything that can help build that story of why this patient must be on service. You want to use any type of interview techniques that are important about symptom management, etc. Anything at all like that. And it needs to be signed and dated by the person who's performing it, clearly titled Addendum or a separate section of the certification. Must attest in writing that he or she performed the encounter, including the date of the encounter. And now one would think, you sign something, you say you did this, blah, blah, blah. You would be surprised how many times it's difficult to find a date on an encounter. So do not take that sentence for granted, because it's important that there is a date on the encounter. The nurse practitioner, PO, physician assistant, or other medical director signing the certification must also attest that the clinical findings were provided to the certifying physician. So basically that document is saying that we went through, we certified this, and now we're also making sure, like a nurse practitioner will write, I spoke with Dr. Smith. Dr. Smith is in agreement, he is aware that we're certifying blah, 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 and you will see that trail within the documentation of the notes and the face-to-face. Also required is a physician narrative at admission. The narrative is to describe the patient's status related to each LCD criteria for hospice diagnosis. Are you tired of hearing me say LCD yet? I think you can see how important I feel it is. Physician signature must follow a narrative. It must include an attestation that the physician composed the narrative based on reviewing the medical record, the examination of the patient, you know, any of the supportive documentation in that medical record that helped to build that narrative. If using justification for a 6-month or less prognosis, other than the LCDs, and again, many hospices work without the LCDs, explain that justification in the narrative. Be very, very specific and provide citations of information for the chart. So you want to make sure to reference what you need, that you pull together in that summary. If you're not using an LCD specific that's related to your fiscal intermediary, anyway, you want to make sure that you pull everything together and justify why you feel this patient should be on hospice. So again, requirements. We talked about face-to-face. We talked about physician narrative. Requirements sometimes can be waived for exceptional circumstances. We do have those 11th hour admissions. You know, we get the call from the ER on a Friday night. And I would imagine we might be getting more calls, because I know I'm in the state of California, and our ICUs and ERs have been at 100% capacity as of late. We're now down from that, thank goodness, but I would be very interested to hear if hospices have been getting calls at the 11th hour for some folks that are showing up. These situations oftentimes fall into those special circumstances where you do not have to have all of that type of paperwork. So because if a patient dies within 2 days of your admission, you know, the encounter is pretty much deemed complete. And again, these are those Friday night or Saturday morning admissions from a hospital ER, and we all know that they come and we have them. So why is documentation so critical? It supports the eligibility for Medicare hospice and all payer sources, whether it's Medicare, Medicaid, any other. It determines proper reimbursement. So if you are providing more than routine home care, you certainly want to make sure to document that and get reimbursed for the work that you are doing. So it's very important that you pay attention to that. It impacts treatment and related decisions. So whoever is doing their documenting, that documentation and information then comes back to the IDG and the IDT, and that's where decisions are made. Maybe they're going to alter the plan of care they want a new course of treatment within the hospice. So that's why I'm saying documentation is critical, because that is what's reviewed in IDG, IDT. Of course, the documentation confirms that hospice is needed. It communicates important information to members of the care team, which we just discussed, and also it confirms and affirms compliance with Medicare regulations. And, compliance is never easy. But if you start out of the gate learning as much the right way as you possibly can and have the tools at your fingertips, your agency will be more successful at this. And if you even have nurses who, have been challenged possibly with maybe inappropriate admissions or things like that, this might be the time to work with them and get the LCDs and go through an admission or two and take some time. It's a good area for your QA to take a look at with your hospice staff. So LCD, documentation guidelines, in determining terminal status, the documentation certifying terminal status must contain enough information to support terminal status upon review. So it just can't be a sentence. Like I said, build the story. Recertifications require the same clinical standards as an initial certification. So you can't just say they've been on hospice, we're going to continue. No, we're recertifying, this is the reason why, and this is all the supportive documentation why. We might have some additional reasons why something occurred, so you want to pull that information together. Again, I've talked about documentation painting a picture. Records should include both observations and data. Always include supporting events such as any changes, especially in the level of ADL activity and what a patient is able to do. If in case there has been a hospitalization or an ER visit, which we do know can occur while a patient is on service. We try to discourage from the ER visits, but that does happen now and then. So it's important to pay attention to that as well. LCD guidelines determining terminal status, will continue on that. Documentation must always have the initial assessment and all IDT, IDG discussions and any evaluations. So that information also feeds into that. Any record showing patient progression of disease should be included. Perhaps their New York cardiac classification has gotten worse. Their ejection fraction has gotten worse. Something like that. You may want to, might be less than 20% now, so you want to include that in there. Documentation should easily identify both the date and time a change occurred if you're doing a change in the level of care. Again, I'm going to say this till I'm blue in the face. You must document when something happened, what was the time, what was the date, what was the action, what is the follow-up, not the action, what was the intervention, what is the follow-up, etc. It's really important to do that. And if you are using any scales to help support your documentation, these are some that you will see. We see FAST a lot when we're, of course, working with our Alzheimer's patients in hospice. That oftentimes is very much reflected in a face-to-face encounter. Nurse practitioners are really good about putting that in. I will compliment the nurse practitioners on that. They are really good about that. That you can use the Karnofsky scale, the palliative performance score, but these are actually a little bit more objective driven ways to help support the need for hospice. So clinical status documentation, you need to show if there's a decline or has there been a challenge, such as have we had recurrent or intractable serious infection, perhaps pneumonia, sepsis, has there been, that emptiness, progressive inanition, where the patient just has that emptiness feeling all around. It could be related to a 10% body weight loss, and of course that if you have a dietitian on service, which again is not a core service, but oftentimes is a very nice extra service that hospices offer. So they may be working with the patient and identifying that there's, we're losing more skin, weight, muscle, etc. here. So those types of measurements oftentimes can help if you send a dietitian out to help support your narrative and what you're doing for a clinical status guideline. You're, of course, looking at anything as it relates to any lab work that you might have, or anything, especially level of consciousness, just basic stuff like that. Look at the vital signs too. Has there been a progression in the blood pressure? Has that changed over time? You really want to take a close look. So why am I eligible? Now, we've talked about a lot of different things, but kind of so when you are that nurse in there doing that admission, you really want to ask the family primarily, what triggered this hospice referral? Was it maybe a lot of hospitalization, frequent readmissions, and ER visits, which oftentimes are very common with the cardiac diagnosis, the heart failure patients. Those are generally your frequent flyers, and those are the ones that have the higher hospital readmission rates. So a place to partner with a health system in your neighborhood is to look, or in your community, I should say, is to look at hospitals with high readmission rates. And that might be a place for your hospice to go and be a great partner to help them bring on some of those cardiac patients. Has there been an exacerbation, shortness of breath, pain, any changes in level of consciousness? Is additional care needed, especially as it relates to ADLs? Multiple doctor visits, poor prognosis, and I put COVID-19 in there with a question mark because I truly believe that, we don't have the diagnosis of COVID-19, but I believe that we are going to see some additional long-term effects of the disease state, depending on different groups, different ages, that might actually be a palliative care moving into hospice type situation. That's just my prediction for the day. When you want to document, you need to document, was there progression on to ADL assistance? Now, I keep repeating that for a reason. That is actually critically important to know the ADL progression and if they are needing assistance. Believe it or not, that is a biggie for keeping them in hospice. Any of their assessment scales, was there a decline? We've talked about the ER visits, MD visits. Sometimes patients still want to continue to go visit their doctor, and what ends up happening is they see their doctor a lot more, and we don't know that, and so all of a sudden we need to be communicating with the doctor, and if we see the patients going into the doctor a lot, what do we have going on here? Laboratory changes, as we've talked about. So if you want to find some significant secondary and comorbid diagnoses to help support the initial why you think the patient's in there, you can look at some things like if you have a patient, let's use the example of a patient with dementia and dysphagia due to this, and they develop aspiration pneumonia. Aspiration pneumonia then serves as your secondary diagnosis that you can then put in there with the dementia in order to help build your case on Medicare eligibility. Another example would be a patient with end-stage cardiac disease, AFib, and they develop an enveloped CVA. The CVA then would be the secondary diagnosis. So I certainly see that, I certainly hope you see that how you're trying to, it's kind of like a related to. This occurred because it was related to that, and that's actually how you're building your case for hospice. And that's on a secondary diagnosis. But if you have significant comorbid diagnoses, which are illnesses unrelated to the primary hospice diagnosis, but they are significant severity to negatively impact that life expectancy of the patient. So an example of this would be a patient has end-stage dementia, but they also have CHF. They're at a New York Heart classification of Class 3. Now, CHF could be a comorbid diagnosis. If we were just admitting the patient for CHF, which we will talk about in a slide or two down, we would need a Class 4 New York Heart Association classification if it was just that. But because we have a dementia with a heart, a CHF at a Class 3, and the odds are eventually they'll move to Class 4, you can combine those. Another example is a patient with end-stage COPD. They have dementia. Their FAST is a 6D. So then dementia would be held to be a comorbid diagnosis. We know with Alzheimer's and dementia-type diagnosis, you usually need a FAST at a 7, but you're at a 6D. You're very close. So make sure to put that in there. You want that in there because the next time there's a review or a summary and you may see the FAST go to a 7 or something, these all help to support, and these are actually metrics that can be used as well when you're trying to make sure that somebody is eligible. You want to make sure that it's not about putting a whole bunch of information down. It's not about just writing whatever and 25 different diagnoses. And trust me, there are patients with 25 different diagnoses. I see them every Tuesday. But anyway, and it blows me away. You need to pull out what's pertinent to, that could be a backup comorbid condition. Not everything is pertinent to a backup comorbid condition. So it's important to know that. So I tried to give you a few examples here. Again, we talked about the New York Heart Association Class 3 CHF. We talked about severe dysphagia and an ejection fracture of less than 20%. If you have had patients that have maybe received a lot of adriamycin with breast cancer, that impacts the ejection fracture as well too. So, realistically, depending on where they are in their prognosis or something, sometimes you will see a cardiac situation occur as a result of the situation, chemotherapy, and the impact on the heart. So you need to pay attention to all of these things. So it's important. We do assessments in hospice. We do the initial assessment, which is done by the registered nurse. It needs to be completed within 48 hours of the election of hospice care, unless the NB patient or representative requests that it be completed sooner. But we are able to do that within 48 hours. And that's really about gathering critical information to begin building that plan of care. Then we have the comprehensive assessment, which is the IDG in consultation with the attending physician and also the medical director. It's completed within 5 calendar days after the election of the hospice benefit. And actually, this is pulling together the physical, the psychosocial, the emotional, and spiritual needs related to the terminal illness. And so it's important that we remember we want to make sure that we are promoting our patients' well-being, that we're promoting comfort and dignity through the dying process. So that's where the IDG and IDT comes in, because you've got the support of the chaplains, you've got the support of social work, you've got the bereavement program coming in, you've got other entities coming in, the volunteers, etc. So this helps us get a broad picture of looking at the patient. Then the plan of care is developed, and the plan of care should include services that are reasonable and necessary for the palliation and management of the patient's terminal illness and any related conditions. It must detail the scope and frequency of services to meet the patient and family needs. It must be established before services are rendered. So you go out and make that initial assessment. You're setting up that quick plan of care so that you can go out and then begin administering such services. And the interdisciplinary team member who assesses the patient must consult with at least one other quorum member of the IDG about this plan of care, as I mentioned. Remember, this is not a one-man show, and I think that's my 4th time saying that. Hospice is not a one-man show. Whoever is conducting that initial assessment must consult with somebody else so that we are making sure we get a broad spectrum picture. All IDG members and the attending physician must review the plan of care. because we're customizing it, the plan of care for that patient versus a cookie cutter plan of care. And we all know with electronic health records, one of the greatest challenges is cookie cutter documentation. And so it's very important that that plan of care is customized. And the hospice physician must also decide what is related or unrelated and what is palliative or curative. So they kind of have the final sign-off on this plan of care. The medical director documentation guidelines, there must be any visit notes. If there have been visit notes, those notes must be continuous, consistent, supporting the terminal diagnosis, again, using any LCD language as appropriate, and make sure you include vital signs, weights, body measurements, even eating meal percentages, all of that. So we've reviewed a lot of that. Also, it's important that you want to use the specific terminology. So we say use AEB, as evidenced by. So this disease has progressed as evidenced by, and then that's where you put your objective information. That's the not subjective at that point. Hospice patient is hospice eligible as evidenced by, and that's where now you've built your case and you can put all that information in. I recommend that every visit note has a part that still continues to address that, so that you show with each visit note that the patient remains hospice eligible. Here is some of the supportive documentation that you want to get, if possible, to begin with. Whether the patient comes from a hospital, if the patient comes from home, you may not be getting some of the supportive documentation, or if they're in a nursing home, you're looking at discharge summary, an H&P, any transfer summaries, there might be an MDS, as I said, depending if they were in a nursing home, any pertinent diagnostic test, dietitian assessment, physician clinical notes, reports from specialists, and you want to make sure that the information is relatively current. You don't want something that's 5 years old. You prefer to have it less than a year old, and then it addresses significant comorbidities, and then it's pertinent to supporting eligibility. So, we usually say less is more. Less is, in this instance, you want to put more in, but you want to make sure you put in the necessary more. If you're just throwing in a bunch of gobbledygook, they notice that, and that's actually more of a red flag, and would make them question you more. So they, as in Medicare and the TPE, so you do not want to just throw everything in the kitchen sink in there. You want to make that story be pertinent. Now, has the patient met all the LCD criteria? Does the patient meet most of that LCD criteria and has documented rapid clinical decline, which is suggesting a limited prognosis? And does the patient meet most of the LCD criteria and have significant comorbidity conditions to impact the prognosis? Those are some of the things that you're looking at when you're trying to consider eligibility. But if you're not working off of LCDs, then you specifically show evidence of eligibility, including the physician narrative. You want to describe how all conditions, comorbidities contribute to that poor prognosis. And again, dates, times, activity, and supportive data. Very, very important. But if you can work off of LCDs, again, it's very important. So let's talk about Alzheimer's. The LCD is specific for Alzheimer's disease and related disorders and is not appropriate for other types of dementia. Again, I mentioned with Alzheimer's, there must be a FAST, stage 7 or beyond. They must be at this stage to qualify. The Alzheimer patient also must be unable to ambulate without personal assistance, unable to dress without assistance. Again, I've emphasized here that ADL documentation is critical. For those of you working with your nurse's aide, we're going to be doing another webinar on nurse and nurse aide and compliance and building the plan of care and ongoing eligibility. We're doing that in March. But this is where it's real critical for you to work closely with your nurse's aide, because they're the one that, is in there working with the ADLs, you've set up the care plan, you're doing care plan oversight, but you also want to look at their notes and bring that feedback into your IDG, IDT, because that's helping to build eligibility and ongoing eligibility. Is there any incontinence, urinary, fecal? No consistently meaningful verbal communication, so you're documenting that. And again, I talked about the presence of any other comorbidities. So that's Alzheimer's. I'm just kind of briefly touching on a few different diagnoses for you to take a look at. If you have a cardiac condition, this is where intermediaries can differ in LCDs. They can differ for cardiac and pulmonary. So it's important to follow the LCDs of your intermediary. They're associated with specific structural, functional impairments and relevant activity limitations. So again, we've got the ADLs and activity there. Any health status changes associated with cardiopulmonary conditions characterized using categories contained in ICF domains. So that's functional domains that we're looking at. Has there been a change in their functional domain? And is it related to cardiovascular, respiratory? Are they only able to walk 5 feet and then they're out of breath? They started on oxygen PRN, now they're on oxygen all the time. Any of those type of things that are related to a decline in their cardiac condition that is impacting their ADLs and their activity. Document relevant secondary or comorbid conditions affecting prognosis and care needs. So it's very important with the cardiac also to support that as well. And again, if you're able to get a New York classification, that is great, because usually people with CHF or angina, really you want a New York Heart Association classification of a 4, which is really an inability to carry out any physical activity without discomfort. We do admit earlier than that, but it's just really important to keep an eye on this. Again, you might be creating the narrative and building the eligibility case because of multiple a few comorbidities. Having a hard time with that word today. Discomfort can be chest, jaw, shoulder pain, or respiratory distress. It's important to continually address that in your notes when you have patients, in your visit notes with any cardiac condition patients, if there's a change in that. Maybe they're having more angina that's not relieved, with medication, so it's important to do that. Symptoms, might even be occurring at rest. Angina frequently on any type of activity, but now they're having that on rest. So you want to show if there's an increase of any discomfort with activity. Do they need to, how quickly can they get their heart rate to calm down? Can they regain their ability to breathe and avoid any dyspnea or pain? How quickly can they sit down after it starts, come to complete rest and return? It's important to pay attention to that too and document. Some patients it's a 30-second response, it's a minute response, then it's 2 minutes, then it's 5 minutes, and you're beginning to see a decline in how quickly it takes for them to then return to what their level of normal is. Also, a documented ejection fracture of 20% or less always supports a 6-month or less prognosis. For pulmonary disease, patients will be considered in terminal stages of pulmonary disease if they have the following: disabling dyspnea at rest, poorly or unresponsive to any bronchodilators. So, and it's evidenced by the bed to chair existence. So what I mean by that is literally they do no more than going from the bed to the chair. And the chair might even be the bedside commode. That's what we're talking about for a chair. So it's important to pay attention to that. And if they are using any type of a measurement that you can see with the bronchodilator that you can measure, put that in there as well too. End-stage pulmonary, you might see more increased visits to the ER for pulmonary infections or respiratory failure. We know that, the fight or flight, the inability to breathe, the panic sets in, so people do tend to want to go to the ER sometimes. It's important to work with these patients and try to get them comfortable at home through these type of a crisis. And maybe they might be seeing their doctors more or making clinic visits more frequently. Their hypoxia level may have changed. PO2 is at 55 or less. PCO2 we've got here is not so great. And oxygen saturations of less than or equal to 88%. So I provided you here with quite a few different things to look at as supportive documentation. You've got possibly, you could be looking at right-sided heart failure, the cor pulmonale that supports the pulmonary disease. So again, you want to do a little bit of digging. Anyway, so it provided you with a lot of resources as well, so that, and I did give you the audit tool here for general inpatient. Again, this is provided by Palmetto, but at least it will give you something to work through and look at if you do have general inpatient, so that you know what to pay attention to, what the checklist is, etc. There are some hospice pamphlets, there's coverage, different types of things there. Again, the hospice benefit toolkit, so that you have the official government handout that you can give as well, and some other areas here. Again, I've given you the link to the hospice chapter. And I believe that winds this up. That's a lot of information. I know that's a lot of information, but you can do it. So any questions, Sid?
Thank you, Kathy. At this time, if you have any questions or comments, please put them in that Q&A box. We did have a couple questions come in. NYHA class, do you need a doctor's order to select?
No, not that I know of. No, not that I know of.
For continuous care as a level of care, do we need to send RN every 24 hours to reassess the patient if there's a need to continue CC or discharge CC?
Yes, absolutely. I would recommend sending a nurse in every 24 hours just to assess the situation and do a documentation on that. Yes, yeah, definitely. Something, I know sometimes it's a little bit challenging, but it almost seems like overkill, but visit more frequently in situations where you are outside of routine home care. I always err on the side of visit more, get a nurse in there, document, do a quick assessment of the last 24 hours. It will just help support your case. Absolutely. And let's see, what recommendations? I see a couple, thank you very much for the people that are thanking me. I'm glad you really enjoyed the webinar. I love hospice and I love all of you that work in it, so that's kind of you. But a couple other questions here I just want to answer quick. What recommendations do you have regarding ongoing hospice Medicare eligibility and IDG, IDT? Many times when I'm brought in to work with a hospice, one of the areas that I find as a shortcoming, or let's put it this way, an area for an opportunity for growth and improvement is IDG, IDT. I think it's important to keep an eye on, bringing in a list of your patients that you want to speak about, patients that were recently admitted, patients that will be coming to the end of a certification period in maybe 2 to 4 weeks that you need to be talking about, so that you keep all of this information on the forefront and that you're always talking Medicare eligibility at every IDG and IDT. I find that when I sit in some of the hospice IDG, IDTs, people are bringing good information back, but they're not linking it to eligibility. So it's very good in your team meetings to always discuss, start using the lingo, start using the language, start speaking like that, so it's a agency culture that you're making sure you have hospice eligible patients, etc.
All right, testing audio. If anyone can hear me, can you please type in the Q&A chat box? And Kathy, can you go ahead and say something?
Yes, I'm here now.
All right. I'm so sorry for that, folks. For those of you that have stuck around with us, thank you very much. Kathy, I'll just have you redo those last two questions, and then I'll wrap up the webinar today.
Certainly, certainly. And thank you, everyone, for being so patient. It never fails, a little glitch now and then, but we did well. So my last two questions dealt with about a hospice agency, what advice I would have for a hospice agency regarding eligibility and audit issues. And I said that it's important to work really closely with your IDG and IDT, and to make sure that you bring into that information, to the conferencing team meeting with you, what patients were just admitted. There needs to be a list. So your clinical managers, your supervisors, however you have that set up, as well as what patients will be, need to be recertified, what patients have been on service 30 days, where are we? You need to constantly be talking Medicare eligibility, making it part of your culture. And part of one of the best places to start making it part of your culture is in IDG and IDT. So I hope that is a suggestion that helps you, because I love IDG and IDT, and I think that's a great way to stay on top of a patient's eligibility. And then my other advice that I had here was not everybody makes a great hospice admission nurse. Not all of us are talented in all areas. I used to think we could all do everything, and in my old age I've learned no, we can't. So work to people's strengths. It's important to work to people's strengths. So for instance, if you have nurses that end up being better at admissions and determining eligibility and pulling that whole piece together, then maybe it's important to have admission nurses. And work from that standpoint also. If you have nurses that are more challenged with that eligibility piece, maybe they then take the case over, and this is where you're constantly discussing it then in IDG and IDT, so that everybody then starts speaking and learning it a little bit more. But basically that was all that I was saying. So I think, Sid, that wraps it up from my end, other than to say thank you to the group. It's really been fun.
Thanks, Kathy. And it looks like we do have a last-minute question that came in before we wrap up the webinar. To follow up on CCRN every 24-hour reassessment, should it be in person, or can we do telehealth due to COVID?
I think basically as long as there is documentation. Now, it's not a billable visit with telehealth. You do realize it's not a billable visit with telehealth, but you can do a telehealth visit. I would not make every visit telehealth, but yes, you can use telehealth. Just realize that's not a billable visit.
Thank you, Kathy. Are there any quick closing remarks you'd like to leave us with?
No, just everybody, again, you're doing great work. I think there's tremendous opportunity in hospice, a continued opportunity for hospice. And so keep up the good work. That's all. That's all I have to say. And be safe.
And we would like to thank you, Kathy, for sharing your time and expertise with us today. Don't forget, any additional questions can be emailed to Kathy, and her email address is listed on the first and second to last slides. On the very last slides, you can use those links to submit a webinar evaluation, or if you'd like to order the recording of today's webinar, you can use that Contact Us link to get in touch with me. We appreciate any feedback you have on the webinar. On behalf of Kathy and your state association sponsors, thank you for trusting us with your training needs. We look forward to working with you again, and you may now disconnect. Thank you and stay safe.